Okay, for this section, we're going to kind of classify the different zygomatic structures, and this is really important to have because not only from a CT scan or clinically, you can kind of determine whether you're going to do a channel osteotomy, you're going to go do the slot technique, or whatever the case might be. The zygoma anatomy guided approach is kind of a more of a international classification that has come up in the past several years that kind of determines what kind of zygoma complex we're dealing with, whether it's going to be an extrasinus implant, it's going to be an intrasinus implant. It's nice to have. I mean, you don't have to kind of know the classification every time you do a case, but it's just nice to know about it and maybe document it because it's pretty much the way that everybody does it. Now, there's different types. We'll start with the A0, so Zaga A0. Usually I just write this on my clinical notes that, look, this is the kind of complex that I was dealing with. This is a type of maxilla that you can see that the maxillary wall is pretty flat. It's not convex. You have alveolar bone at the crest of around 4 millimeter or so. So this is the type of thing that we want to maintain, that alveolar bone. So here I'll do a tunnel osteotomy. Basically, the implant's going to be intrasinus path. I've lifted the membrane back. That opening hopefully is the size of the implant or just a little bit bigger if it's necessary. And we place the implant. So you're engaging not only at the apex, but you have some engagement at the crest as well. Now, the important thing is to dissect that membrane superiorly and inferiorly off the wall of the sinus. If the membrane tears, you cannot maintain the membrane, it's okay. You just move on and we go from there. It's not gonna necessarily change much. Obviously, keeping that membrane intact, like I talked to you about earlier, is going to prevent you having major sinusitis issues and other complications. So I like it. I like to keep the membrane intact. And obviously, I keep saying that, but that's kind of an important fact there. The A1 technique, similar. You can see the sinus wall is becoming a little bit more convex. And there's still bone at the crest. So we're still going to have bone covering the neck of the implant. Still going to do the tunnel technique where most of that implant is going to be intrasinus. But you're going to get some portion of that implant where eventually kind of in the midsection is more of an extrasinus. This, again, doesn't cause any problems with the patient. They're not going to feel it. There's nothing different. But the important thing, again, is that you have apical penetration of that implant, and at the crest, you also have bone surrounding the neck of the implant. So the A0, A1, very similar in nature. The A2 maxillas, now things are becoming a little bit more trickier because the crestal bone is very minimal. There is no crestal bone. The sinus either dips all the way down to the crest. The maxillary complex is not extensively convex. It's still more straight. But there's the alveolar housing is not adequate in that area. So you're not going to usually have bone covering the neck of the implant. And again, it's okay. That's the way it is, and that's the way we do it. But you're engaging at the apex, of course. This becomes a little bit more of an extrasinus path. So you're going to see most of that implant in that area. And that's the whole osteotomy is a little bit more buccally shifted, of course. Now we get to the A3. That implant, that maxillary wall is very concave there. You can see that. You have maybe some alveolar bone to deal with most of the time. So the A3, the difference between the A3 and the A2 is that alveolar housing. It is a buccally shifted more implant because you kind of, that's the way the anatomy is. But that midsection of that implant is going to be really extrasinus. I mean, that's really not going through the sinus. That area, all you have to do is just lift that membrane back a little bit and you're set. You don't have to really dissect that membrane too much in that midsection. But you still have to dissect it inferiorly where you're inserting the implant. And so because that's where you're going to be, the neck is going to be housed, basically. Now, A4, very tricky. These are very, very atrophic maxillas. This is definitely going to be more of a channel osteotomy. There's been cases where I've done these where I haven't even had to lift the membrane that much because that implant is so extrasinus. Now, the problem with these is after the fact. I mean, you can get a very nice, stable implant in with good fixture and good position. The problem is that tissue going to dehisce on the buccal. These are the ones that I'm really going to cover this area with a buccal fat pad, pedicle flap, to make sure that keratinized tissue forms there and we don't have any dehiscence. This is the only thing that worries me about this, is that neck becoming exposed and becoming basically a hygiene problem for the patient. So those are the classifications. Let's look at, again, these are more of a panorex kind of visual of these. I want to look at some of these. Look at these pneumatized sinuses in some situations. You can see maxillus rivera very edentulous on the top, very atrophic, minimal crestal bone in the molar premolar region. The lower implants are dentate. The lower cases are dentated patients, but very pneumatized sinus or infection in areas where you cannot place an angled implant going anteriorly in the premolar region. Therefore, you got to go zygoma here. I have no bone in those distal aspects to place any angled implants. Anteriorly, we do. Anterior is fine. We can put our 2 implants in. But in the posterior region, this is where I choose to do zygoma, not only because the sinus is pneumatized, but those large infectious areas. So this is how I kind of make a determination of whether I'm going to do a zygoma or not to give the proper AP spread, obviously, in those situations. Here's a case where I'm going to do a unilateral zygoma. You can see by the red lines how pneumatized that sinus is. But on the left side, I can get a nice angled implant, have good AP spread in the second premolar region. So I'm not going to do a zygoma there. It's not necessary. But on the right side, that sinus comes all the way forward to the canine region. So I'm going to do a zygoma on the right side, but more of a traditional All-on-X on the left side. Here's a very difficult case. The right side, the left side, having some bone to work with, maybe putting a single implant in the front. And I'll show you this case when it was finished later. And maybe putting an angled implant in the upper left area, even though there's a big big infection on that premolar region. But the right side, we have no bone. I mean, it's a flat area, very complex. We ended up treating that right side with a zygoma, pterygoid, and a short implant in that front area. So these are the kind of things you're going to come look at when you determine to do zygomas. So not only from a panorex version of it, you're going to see what does those sinuses look like. You're going to look at the Zaga classification and then to see how your osteotomy is going to go, if it's an intrasinus or an extrasinus approach in doing things.